Okay, here we are. Now we're recording and we're live with both of us here. So, for the recording, Dr. Clack, how about you go ahead and introduce yourself again? Because some of the people are just coming on, so they're
Okay.
not familiar with you yet.
Okay, fine. Hi, I'm Dr. Angela Clack. I'm a psychologist and licensed psychotherapist in Southern New Jersey. I currently have a private practice full time where I treat adults and children as young as 10, families, couples, and primarily the clients that I service are people struggling with depression, anxiety, relationships, kind of interpersonal distress, lots of trauma in their lives. And I've been doing this for about 20 years, maybe more. Oh my gosh, I was just looking at my Vita the other day. I had an opportunity to speak to the graduate students at Chestnut Hill College about my path and my career as a psychologist. And I was looking at my Vita, I was like, wow, I've been doing this a long
You
time.
don't look like it though.
Oh, thank you. I'll take that.
Awesome, awesome. Okay, so I guess I'll give a quick introduction to who I am as well. So my name is Lynette Davis. I am a mental wellness blogger over at LynetteDavis.com. How I know Dr. Clack is Dr. Clack's actually one of my clients.
Mhm.
I run a company that helps professionals such as Dr. Clack, like private practice professionals, women coaches, and consultants, consistently market their businesses and manage their back end of their business as well. How I ended up doing that is actually, I come from a social work background. I've worked with youth, mostly girls, actually, as a group home mentor and a behavioral assistant. And I also worked in the field of addictions at one point too, working on the administrative side. And I found that I actually enjoy doing the administration side and the research side. So here we are, um, talking about reducing the stigma of mental illness and increasing awareness. So I'm going to, again, recap why we decided to kind of do this topic. So every Wednesday, to my knowledge, it is every Wednesday on Twitter, there's a chat called Mental Health Chat. And I believe it's hashtag MHChat.
Mm.
And they do different topics each week. Now, this topic was not the topic that they just had yesterday. I believe yesterday was anxiety, so we're a week behind. But the week before that, they were actually talking about stigma, and I thought it was a great topic. Oh, awesome, awesome, Nathan. Nathan. So Nathan said our topic is in line with what he's doing. So
Oh, that's awesome. Yeah.
I'm really excited
Great.
about that. So yeah, awesome because like I said, technically we're kind of a week behind because this was their topic on mental health chat a week prior. But
Okay.
I didn't want us to not go over it. So some of these episodes we're probably going to piggyback off of the things that I'm listening to, well, tweeting about in the chat the week before. And sometimes
Okay.
we're just going to come up with some topics based off of what's going on in Dr. Angela's group, which she'll tell you about later, as well as the things that I'm experiencing through my research, as I'm currently writing a book about women entrepreneurs who have to manage their mental health issues. So let's kind of dig right into this topic for the evening,
Mm-hmm.
which is talking about reducing the stigma. So one of the things that I noticed, I'm trying to actually phrase it the way I kind of saw it on Twitter and how it went. So they were kind of asking, is stigma a question of fear, ignorance, or something else? And does mental health stigma influence mental health services? So I wanted to know, Dr. Angela Clack, as a psychotherapist, what's your take on those? Well, let's kind of start with those two questions. What's your take on this topic?
Yes, yes, and yes. Stigma is about fear. Stigma is about ignorance. Stigma and ignorance, not in the sense that people are purposely not knowledgeable about things. It's just it's just the kind of naivety that people think that um, and are functioning off old myths about mental health and if you watch movies about people laying on couches and people are crazy, that's old myths, that's old ways of thinking. So it is about fear. And it's really, I find it mostly in communities, minority communities of color, that historically have not trusted institutions to help them. So the stigma is that you are crazy, or that they're going to, you're an experiment for people. So there's a lot of history that we have to overcome to help people feel comfortable and safe enough to trust the mental health community. So it is about fear. It's absolutely about ignorance. And there was one more question that you had. I think there were three things you said: fear, ignorance, and something else.
Actually, that's what I said. It's something else.
Oh, okay. All right.
I say, is it a question of fear, ignorance, or something else?
Okay. I think that something else is the getting over the history of what's happened to communities and people of color who have trusted doctors and physicians and institutions in treating them for medical issues. And so there's this distrust of mental health or doctors and physicians, professionals, period. So so I think it is, the stigma is fear, ignorance, and a level of distrust in the mental health community.
Definitely. I honestly think that besides just within the community too, I think, and just kind of from what I've seen as somebody who had to kind of escort clients into their treatment, that stigma actually goes both ways. So not only is it the person who's being treated for certain issues such as mental illness, and trying to overcome different stigmas that's associated within their culture, but it's also the culture of the providers who might come to the table with different stereotypes about the people that they're supposed to be treating and helping, especially if they might have been in a practice for quite some time, and they're not used to having certain clients that at one point when maybe they started their practice, for instance, certain things were not allowed. Interracial couples were not legal. There were no gay rights, so now they're getting a new clientele come in of people who are having issues because of how society is viewing them, whether or not things are legal, but how society is still viewing them as a present, because as you know, just because certain things come into law, it doesn't mean that the culture shock is not there already. It's not present. So I think also the stigma that we have to kind of overcome is even within the professionals who providing the service.
And part of that is part of it I want to attribute to a lack of people's culture awareness and being in touch with their own biases and thinking that, well, I can withhold that or I can restrain that as a clinician. It won't interfere with my relationship with my client. Well, it will, and it does. It's really, you really have to be honest with who you are and your own value systems and who you're comfortable working with, and or you get training or you get some kind of supervision so that you know how to work with people who may be from a lower socioeconomic level, or people who are of color, or people who have a different gender identity, because everybody's not trained the same way. And if you're not open to learning new ways of working with people who are different culturally, racial, whether it's religion or whatever, then you will run into problems with the population, and your biases are going to show through. And that will make people further mistrust mental health providers and physicians in general. So we're back to what we talked about before, that if you don't know what you're doing, you need to get some help so that you don't make people think that they're still not doing the right thing by seeking help. So it is a little complicated, but part of our training is to stay on top of being culturally relevant with culturally relevant practices. We're supposed to have continuing education credits. Every regulated profession is supposed to do that, but it doesn't necessarily mean that that person, the provider themselves, are comfortable providing services for people of different ethnicities and diverse backgrounds. So that can be an issue. Absolutely.
Definitely. So I'm sitting here, I'm kind of reading with Nathan wrote. Nathan, I hope I'm pronouncing your name right. And he was kind of saying that, okay, awesome. He said, yep. That he's not so much concerned about it because he gets to work with people who have realized that they're suffering and they want to just kind of do the work. Do you find that you have more of those instances, or do you find that when you work with clients, I'm going to say clients rather than patients,
that's fine,
who are ready to roll up their sleeves and do the work, or they're really skittish and they're ready to head out the door when they first come in to see you?
I think there's a little bit of both. I think they're skittish when they make the phone call. So there are a lot of folks who, when they come to me, they say, you know, it took me a really long time just to pick up the phone to call and make the appointment. I really work hard, and I feel like I do a really good job of helping people to be informed and comfortable enough when they come in that I'm removing that barrier so that they can actually say to me, you know, people think I'm crazy if I come here, or I didn't know. And I'm gonna, let's just keep it real. They'll say, well, I didn't even know Black people came to therapy. And, you know, so I really spend a lot of time dispelling a lot of myths so that they can get past that. But the stigma is real. It exists. People may not say it, but if you ask them, well, what were you doing before you came to me if you've been struggling with this for so long? And they'll say, I was afraid. I didn't want people to think I was crazy. I didn't want people to think that there was something wrong with me. So the word stigma may not be in their vocabulary, but there were barriers to them getting help. And if you open up that conversation, you'll figure out it was a fear of being labeled and getting a diagnosis and all the other kind of things that come up with myths when you just don't have the information.
Definitely, definitely. And you know, I remember that originally, like, you know, I kind of told people in the introduction, originally I was on the other side of the couch, so to speak, working as a youth counselor and then working in the field of addictions on the side where I was taking people into treatment and things of that nature. And I find it very interesting that while I was working in social work, I found that, and I mean, this might not necessarily be the case for other people, but I found that sometimes social workers themselves are some of the ones who are most opposed to having to go to counseling themselves if they're having a hard time, because they now have this image of themselves as, well, I am the savior, you know, piece here, and I am the leader and I'm supposed to have it together, and I can't fall down and need to go to see somebody who I've been taking people to see, or I've been working with these clients myself. Mm-hmm. And I think there's a lot of stigma for professionals who are in the space not wanting to let down their guards. Now, this is not obviously not necessarily those who are in the profession and they already believe in being a professional. You should go see one as well. Not only for the sake of just having a mentor, but just, you know, kind of keeping yourself balanced and just believing that, for instance, you know, seeing a mental health professional is something more like an ongoing practice to keep going. Have you had any of that, you know, come to you? Because I know, for instance, when I went through my own dark night of the soul, it was extremely hard for me to want to go to counseling because I'm like, I'm going to go see the same clients that I was delivering over here, you know, and, you know, and I think it makes you really conscious about how you look at people yourself when you're working to help people. And I think that's really important when we're trying to talk about reducing the stigma, because sometimes in the process of doing that, you like to pull yourself outside of it as if I'm talking about the other, not me. Yes, let's reduce the stigma and I'm an advocate and everything like that. But no, not me though, not me. So it's kind of like there's shame in that.
Yes.
At the same time, while you're sitting there, you know, trying to advocate and everything like that. And I think that comes out and when you're trying to increase awareness, you know, I could be wrong. What do you think?
No, absolutely. That's been an issue for years. So, and let me go back, depending on the training program that you're in, as psychologists and people who were trained as psychoanalysts, part of your training when you're in graduate school is you have to be in some kind of therapy at some point, because the point is so that, one, you don't get overwhelmed with the program, and two, because it does give you perspective, and three, it's designed to help you kind of work out your own stuff before you take on someone else's life in your hands. So depending on the graduate program, we were encouraged to seek out our own help. Number two, it's very important to have a good balanced mental health, and that may mean that you need to be in therapy too. Now, sometimes it may be called supervision or consultation. That's perfectly fine. That means you found a supervisor as a clinician to go to talk about your issues, whether you're having a hard time dealing with a particular disorder or client issue, or you recognize that there's some countertransference. So something I'm going through is interfering with my relationship with my client. I've had clinicians come to me because they're going through a divorce and they're having a hard time working with their clients who they are providing therapy for, who are also going through the divorce because they're losing perspective. So it behooves us as clinicians to do exactly what we preach, and also to follow our ethical guidelines, just like physicians do, which is the oath is to do no harm. And that means we have to be well to be able to take care of other people. But you're right. There are people who will not seek help because they will see it as an embarrassment. So here we are educating our clients, and so happy that they're coming in to pay us to do a job that we ourselves don't do. So one of the things I'm very careful about is I won't give my client an assignment that I wouldn't do myself. And I've seen people do that. They have their client may do some kind of shame attacking exercise. And I think, well, would you do that? And they're like, probably not. So I'm like, then when they don't do it, you can't get upset because you wouldn't even do it yourself. But part of this work, because we take in so many and we internalize a lot of our clients' issues, if we're not setting really good, healthy boundaries and we don't get balanced, and we're not nurturing ourselves, whether it's through psychotherapy or some other form, we will end up damaging our clients and not even taking responsibility or realizing what we've done. So it is definitely like practice what you preach. We need to reduce the stigma by being okay with seeking help for ourselves too.
Absolutely, absolutely. So I'm going to backtrack a little bit because I want to go back into something that's kind of a sticky subject, because I think sometimes when we talk about stigma and cultural influence, people kind of shy up about this because, everybody wants to be right, but nobody wants to listen to the other.
Okay.
At the same time. So, do you think that there is a opportunity for a larger stigma to occur in and I'm trying to phrase this the right way, for people who are from more like lower income type of families, people who are from cultures that are a little bit more oppressed than others? Do you think it makes a difference, or is pain pain?
Okay. I think I need you to clarify that a little bit so I can answer it. Say that again.
Okay, I'm gonna have to rephrase it because I'm saying it and I'm like, in my head it sounds good. So let me kind of rephrase the whole thing, and try to put it in more simple terms. In terms of culture, do you think certain cultures? I'm totally going to redo this question. Do you think certain cultures will experience stigma within their community much more than other cultures?
Yes.
I think that's a little bit more simple.
Absolutely. And that is again, culture such like I've worked with families of Asian descent, and there are strong cultural values tied to seeking help and going outside of the family. Of course, primarily I work with persons of African American descent, And yes, there are biases and cultural norms and things that maybe people have not subscribed to psychotherapy as one of the ways is coping, because it is perceived as a weakness, and family secrets. A lot of people of color grew up in homes where the motto or the mantra was, what goes on in this house stays in this house. And what's happened is some of the stuff that's going on in those homes has been very traumatic, and the family secrets have been passed on intergenerationally. So you see generations of folks going through abuse and trauma because very early on, the family motto was, we don't talk about that, or we don't go outside the home to share those kinds of things. So in terms of economic, there's a real lack of access to resources in some of these communities. So they end up going to places that may not treat them so well. They're on long waiting lists, and that discourages people from wanting to get help. So I definitely believe that it matters who you are, where you live, and what you have. Absolutely.
Awesome, definitely. And I've seen the same thing. And what's funny is, now, as much as I primarily work with women myself, I find that there is a huge stigma for men to seek help. I was actually talking to my best friend not too long ago, and it was a joke when I first said it, but now that I'm thinking about it, it kind of made sense. I realized that women are the ones buying all the self-improvement books. They have stats on top of stats about who's really investing in all the self-help talks, who's going to all the workshops specifically about empowerment and personal development and self-love, whereas men might, more or less go to something about money making and, or real estate, or, things of that nature. It sounds like a stereotype, but, this is, things that are going on. And I would wonder, how are they taking care of themselves? Who's feeding their brain? Who's feeding their souls? Who's helping to nourish their hearts when they're having issues, if they're not picking up the phone and taking, someone like you, Dr. Clack, up on that free consultation so that they could come in and get a mental health assessment? How do we even begin to, as this topic says, reduce the stigma of something like that, especially if you're a man and you have just lost your job and you are the provider? You are supposed to be the breadwinner, and society has told you that if you are not being able to provide for your wife and your children, then you're not a man, and having to deal with that and not feeling like you have anywhere to go, because doing something like taking care of yourself to go to read a personal development book or go to a seminar that's going to talk about self-love rather than how to make more money, or picking up the phone and talking to a psychotherapist or a psychiatrist, or even just a main doctor to say, I'm depressed. I have the world on my shoulders. What am I supposed to do with this?
Yeah, when it comes to the socialization of boys and men, gender is a factor in whether or not they can be vulnerable enough to talk about very difficult things. So they use other devices. So men may use the gym, they may use relationships with other people, but they don't necessarily come to a mental health therapist. I think when I think about my practice over the last 15 years, when men come in, it's at the insistence of a female. So it's either a wife and there's marital or a couple relationship problems. They come in for anger management, or I'm trying to think. On occasion, I've had men come in for maybe grief after a loss. There's not that many men who come in because they will identify themselves as depressed, fewer come in because they're anxious, and even fewer come in for anything other than that. It is very difficult. Because I'm aware of that, once they get in the door and they picked up the phone and they made the call, I work really hard to join with them around the fear of being a man, coming to a female, or coming to therapy at all, and feeling ashamed. So I work really hard to reduce those kind of things before we even get into the issues. Then there are those men, there are few, maybe other clinicians may see something different in their practice because I'm a female, maybe men are going to see a male therapist. That might be true too. So I may not be getting the larger male population in my practice because I'm a female. They may feel more comfortable talking to a male therapist. That may be a part of the why I don't see a lot of them. But usually when they come in, it's marital problems, relationship stress, maybe job stress, maybe some vocational stress, and then infidelity a lot in my couples therapy. That's typically when I see men, and then anger management.
Definitely. And from what I can remember when I did work in the field, as we say, well, you know what? Honestly, because of where I was and who I was working with, which was people supposed to come in for substance abuse treatment, and we were in line with DIFAS, which I'm not even sure if they're called DIFAS anymore, but we'll basically say the Division of Youth and Family Services, because I know pretty much every state has a version of that.
Yes.
Usually they're known as the people that'll take your kids, but
right.
And I know pretty much the only reason why most of them came in was because they were being threatened that they would lose their kids. Yeah. So
yes.
So, I wonder if sometimes reducing the stigma of this might be in more men stepping up to be therapists for men. Because, even though maybe men aren't reading the books or going to the seminars, I have found, as I've talked to men, because I'm like, what's up with that? Where are you investing in yourself? They tend to do a little bit better when they have another male mentor in their life. So men learn from other men. And because of that, it goes back to that stigma, especially for inner city youth, for instance, where they might not have a male figure in their life who's telling them it's okay to talk to somebody. They might have men in their life that are telling them, don't show emotion,
right?
Don't do this, and you can't be that if you want to make it in the hood.
Yeah.
So that's just for that. I'm not sure if it's the same way if you're a man that's coming from like a suburban background instead. But I imagine that there's some kind of variation of that, just from a different perspective.
Yeah, you have to have a very different approach when you work with men and boys, because they're not going to be the traditional client who can sit on the couch and just kind of give you this very insightful sequence of events in their life. And but you really have to join with them on some things that interest them, and then you kind of work your way around. When I worked with young men who were incarcerated, these guys could do therapy. They can talk. They may not label feelings. They may not identify feelings. They may not make connections, but they will buy into the therapy if they think there's someone who cares enough to hear their story. And that's kind of where I go. I go with their story. So they may talk about everything else, and they may not do what traditional therapy does. Well, how do you feel about that? What are your thoughts about that? Have you tried this? That's not how they talk. That's not their language. That's not the cultural way that they manage feelings. You got to go with the population that you have and figure out how to help them tell their story in a way that they feel comfortable and trust you, in a way you can hear, and then you work around that. So I know men will do therapy if they feel like there's a connection with the person who's doing the work with them.
Yeah, you know what? I think I agree with you, because actually my internship was actually with the Juvenile Justice Commission, and I worked in a substance abuse I guess it was kind of jail, but it wasn't. It was for those offenders who had drug, charges.
Mm-hmm.
And they were all boys. It was very interesting for me to be there. But but come to think of it, I did sit in some of their group circles, and they definitely had a counselor where they weren't ashamed to open up. Originally they did hesitate because I was in there, but after a while, I remember in the beginning they would tell their stories and they would curse and swear and everything and look at me like I'm so sorry.
Yes.
And I'm like, no, just be yourself.
Yep.
And they were able to open up, but I think it was because he was a great facilitator, and he made them feel comfortable enough to not only share with him, but also in that space where there was a young one. I was the only girl in there at the time, a college student at that time, as well as the rest of the boys who were in that facility as well. So,
well, let me make a point. I think you make a really good point, because when we talk about who we're seeing in the drug treatment programs, you were talking about how they were males. And one of the things that I'm aware of is that because men may not show their face in therapy, they may be self-medicating with street drugs. So instead of them going to a psychiatrist to get something for depression, they're using marijuana or something else or alcohol. And so they are showing up in treatment facilities for drugs and alcohol, and or a program that does both, which will do mental health and treatment for drugs and alcohol. So they may be self-medicating with something, whereas women will be quick to go see our GP or a gynecologist or whomever and get medication for anxiety or depression. And that's not typically meant to go in and say, I'm depressed.
Good point. Yeah. You know what? And I wasn't even thinking about that when I said it, but yeah, that makes sense. And sure enough, because at that time, yeah, that's where all the guys were. They were in the AA, the NA. They go to those groups.
Yes.
And they'll have the sponsors. And again, yeah, so I guess it goes kind of both ways. Most of the time women do want to work with women, and men want to work with men. So we're coming to the late hour. I'm rubbing my eyes. My contacts are drying up. I want to kind of end this discussion with, now we've kind of already talked about it, but I want to talk about what are some of the ways that we can challenge and change mental health stigma. Because, even if we can kind of bring up one thing, because we kind of went into different segments of how this stigma can arise. And some people probably listening like, well, yeah, it's definitely some stigma if you're going to group me with some substance abuse users, and I'm not, but I'm like, now being that my background is more, my work was more in addictions. Addictions is a very broad field, actually, and it's definitely much deeper than just alcohol and drugs. Right. So, but let's talk about solutions.
Okay. I think that's a great idea.
So what do you think are some of the ways that we can challenge and change the stigma? And the process of that, kind of increasing awareness.
Education. I think education. I think we have to go where people are. So if churches, churches are full of people every Sunday. If churches have opportunities to talk about people taking care of their mental health, if we go to the schools and talk to the schools, particularly, most schools now have some kind of mental health component or a social worker or someone, or at least they have a way to refer kids if there's a crisis. But I think schools are important to have that conversation, because we are finding a tremendous amount of kids committing suicide. And we know that this can be a contagion, and we know what happens to kids who find out about kids who can. It can just be a very bad scene. So I say we as mental health professionals and physicians, I think as mental health professionals, we have to also educate physicians. And sometimes I get the opportunity to collaborate with physicians, and we share a patient, and it works so well. It's awesome. But a lot of times we don't get to reach people because people are busy, or they just don't see the value in talking with a person's therapist. But again, I'm always mind-body connection. There's always a connection between how you feel and your mental health and your physical health. But if we can go to where people are and have conversations about what mental health is. Sometimes we may have to change the word. Mental illness scares people, but it is what it is.
Yeah.
It's a fact. It's true. We know that it exists. Depending on who we're talking to, we might have to say if you have an emotional health problem or emotional disorder. Sometimes we have to may help people with the language. That's a stigma issue. That word mental illness has a lot of stigma. So, okay, let's change the word depending on where we are and give the same information. So all of the thing we do is how do we get to the places where the people who need to hear it? Social media is strong. I mean, look how many people are on social media. Anything we can do to promote awareness on our pages, if we're out somewhere and we're seeing somebody being mistreated because of a mental illness, and we step up and say, look, it looks like this person is struggling with something. Let's try to step in and help them. So part of this is also about what we do, how we manage it, and how we model for people how to handle people who have mental health issues.
Definitely. And me personally, I mean, obviously, one of the things that I do is join with people like Dr. Clack and have shows like this where we can have this conversation in a live stream despite technical issues. But we made sure the show went on so that we can have this conversation. And luckily we can record it. And what's cool about technology like Blab is, we can record it, we can embed it in our websites, we can place it on YouTube, we can share it on multiple channels so that we can get the conversations out and going and flowing. And a prime example of just letting something take an organic route. Yeah. This whole conversation was because of a Twitter chat that I saw last week. And I just wanted to continue the conversation on a different medium. So, it spreads. You're watching tonight with us. You can continue this conversation as well. Right. Maybe something we said might trigger a new conversation that you might want to bring up, because we did talk about different aspects of stigma. Yeah. And you might want to address one in particular. Nathan was here and he's a student and everything like that. And this happened to be some of the work that he was doing, so just piggyback on the conversations. We're not competition. I think when we begin, I think one of the best ways to kind of reduce stigma is to start reducing it within those who are advocates and professionals themselves. If we're here to work for a cause, then we need to try to be on the same page, because we're supposed to be working towards the same thing, which is ultimately mental health. And I'm definitely with Dr. Clack. I firmly believe in a biopsychosocial spiritual model, actually.
Yeah. Right, exactly.
And I believe that we can definitely increase awareness and reduce stigma when we all work together from our various fields to accomplish one goal of making sure that people know that they're not alone, that, even though they think it's just them, it's not. And then working towards making sure that we're able to give people access to treatment that works for them. Because I firmly believe that there is not a one size fit all model to anything, because we're all unique individuals. And what works for one person might not work for another. And I think that's also a part of increasing awareness, because sometimes in our bid to promote our own work in our research, and I can say that because I am a researcher, and we try to be as objective as possible, but we're human. So there is some, subjective words in what we put out there, but just knowing that people need to know that if something didn't work for them, that wasn't the only way that they can find a path to healing. And I think that's really important with awareness.
Absolutely. I tell people, you shop for a therapist like you shop for anything else. Like you're looking for a home. A home is a major purchase. You buy a new car, it's a major purchase. So you don't necessarily buy the first house you walk into, because it might not fit you, might not have exactly what you need. It's not your color, style, whatever. And the same thing you do with a therapist. You don't have to sit with someone who you meet and you don't feel like they can relate to you. You shop around till you find someone, and it may not be the person of your same color. You may work better with someone of a different ethnicity. So don't feel you have to be locked into someone because you have the same religion or you have the same value system around everything 100% of the time. You go with who seems to feel comfortable and whom you think you can trust and where you fit. But you take it seriously and you just really do your homework and make sure the person can provide the kind of care that you need.
Absolutely. Absolutely. So before we head out, Dr. Clack, how can those who were able to attend live, as well as those who are going to be watching this recording, how can they get in touch with you again?
Wow. Thank you guys for being on this evening. I really appreciate you hanging in there while I was kind of lost in Blab world. But that's the power of perseverance and the importance of this topic for us that we were determined to get on tonight as we all lead very busy lives. So my website is www.clack, and my last name is CLACKassociates.com. On Facebook, I have a couple of different pages. So you'll see my practice page, which is Dr. Angela Clack. Just put that in. I have a personal page, Angela Clack, which is open to anybody. I do the same thing. My personal and my practice page are very similar, and it's all about healthcare and mental health care and just really healthy posts and things. And then finally, I have an online community group for women of color, and it really is a support place for women to get empowerment, encouragement. I post articles, information about health, wealth, wellness. It's a little bit of everything, but it's a place for women to be able to come together and just really see other things that talk and speak their language about being a woman of color and wellness. So thank you again I appreciate you setting this up, Lynn, for me tonight so that I could get on and make sure that this information, because we are working to reduce stigma, is talked about, and that we continue to broach the subject so that people can feel comfortable in getting some help. Sometimes I see people who are just, we call them worried well. They just want to get a perspective. It's okay. I mean, you just want to say, look, I only came in because of this. And then it opens the door for a different kind of conversation. You just have to trust the process.
The process works. I know that phrase.
Yes. Trust the process.
Awesome. Do you mind if I put the link to the group? Because I know you have to approve them anyway,
sure,
but
sure,
for those who are looking. So I just put Dr. Angela Clack's Facebook community in there, and this group in particular is for women of color. However, you can definitely, it's not there yet until after my summit, but I'll definitely be having more resources on my site, although my focus is more for entrepreneurs who have a history with mental health disorders. See, we're talking about changing orders. I actually prefer to use mental health disorder over mental illness. But I don't think it detracts from anything in that case.
Exactly. That's right.
In that case. Mm-hmm. So, and you can find me over at LynetteDavis.com. It's my name. Pretty easy. I would say you can Google me, but I believe that there is another young lady who actually, and we could talk about that next time maybe, who actually, we had the same name, and she actually was what you were talking about, a teen suicide. I don't know her full story, but I know that we had the same name. Wow. So I wouldn't say Google me. But you can reach me at LynetteDavis.com, and I'll be having more resources there. I know I'm actually working on a guide right now called the ABC Method to Managing Your Mental Health. So working on that as a work in progress, but it'll be a free resource on the site, and I already have some free resources on the site. So everyone, I thank you so much again for your patience. For those of you who have been on since the start of us in our tech issues, we truly appreciate you. We truly appreciate you. We have our bags under our eyes. We're both probably looking at the time like, okay, well, good night. So I'm going to go ahead and say that. Good night, everybody. Thank you so much for tuning in. And until the next time, be well.
Good night.